various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speakers for the evening, Dr. M.B. Agarwal sir from Mumbai and Dr. Manali Kamdar from University of Colorado, USA. All discussants and participants to this virtual symposium on B-cell lymphomas. We have a case-based discussion on rational use of polatuzumab, followed by a talk on emerging therapies in B-cell lymphomas. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this continuous medical education series under the edges of Mumbai Hematology Group, Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital, Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes as well, PD Hinduja Hospital, Leelavati Hospital, Fortis Hospital, and Breach Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. I request Sir to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Thank you. So good evening to one and all from India, and maybe good morning and good afternoon for those who have logged in from the rest of the world. Today we have two lectures. The first one by me, which is supported by Roche, and the second one by Dr. Manali, which is supported by Zydus. This webinar is brought to you by Mumbai Hematology Group. As I mentioned, these are supported by Roche and Zydus, managed by Perfect Square. I'm grateful to the team Zydus and Roche, Mr. Yash Kalpesh in the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker this evening, Dr. Manali Kamdar from Colorado, USA. All our discussants were themselves eminent hematologists or medical oncologists, new participants for sparing your Wednesday evening. To give you a flavor of our tomorrow's webinars, we have got two talks again. Tomorrow at 6:30 p.m. IST, we have Dr. Neeraj Arora from Unipath Lab, Ahmedabad, speaking to us on real-world application of whole transcriptome sequencing for classifying the patients of ALL. And an hour later at 7:30 p.m. Indian time and the US Eastern time 10 a.m., we have Dr. Henny Samkari again speaking to us on PK activation in RBC disorders, a new therapeutic horizon. Well, first, my talk. It is on rational use of polatuzumab in newly diagnosed DLBCL, a case-based discussion. This is supported by Roche. So, overcoming the odds, frontline Pola-R-CHP, rewriting the narrative in high-risk ABC DLBCL, a case report. Disclaimer. So, targeting a newly diagnosed high-risk ABC DLBCL with Pola-R-CHP has become the standard of care. Let's look at our case. That's the gentleman. Real life story. The clinical challenge. A patient with slim survival odds. It was more than a year ago, March 25. We received a patient in Mumbai by air ambulance. He was a 64-year-old man brought from Siliguri, which, as you know, is a part of West Bengal. He was diagnosed as DLBCL ABC subtype. He had stage 4 disease with extensive extranodal involvement. His IPI score was 5. Performance status was poor, 3. Ki-67 index was very high, 80. And the LDH was extremely high, 2,860. This was his PET scan showing involvement of multiple extranodal sites. The parotid, numbered as 1, lungs 2, stomach 3, and the spleen numbered as 4. If you look at the IPI prognostic score, he was above 60. He was stage 4. His ECOG performance status was 3. His LDH was sky high, and he had more than 2 extranodal sites. So this gives him a score of +5. The Hans algorithm divides DLBCL into GCB type and the non-GCB type. Our proband this evening had CD10 negativity, BCL6 negativity, and MUM1 positivity. So he was a non-GCB type, popularly known as ABC. You are well aware that the GCB does much better than ABC, both with respect to probability of survival and the overall survival. And the difference is vast. Coming back to our patient, he had pancytopenia. He had a number of comorbidities in the form of ILD, hypertension, diabetes, peripheral neuropathy, and his creatinine clearance was 45. There was a history of heavy consumption of alcohol. When he was transferred, he was running fever, drenching night sweats, and he had lost 16 kg of weight in the preceding 10 weeks. He also had a patch of pneumonitis with mild respiratory distress, although he was able to maintain his saturation. His vitals were stable. There's a past history of tuberculous cervical lymphadenopathy way back 16 years ago. Review of his PET CT scan showed extensive nodal and extranodal disease involving almost all lymph nodes, producing a large mediastinal and retroperitoneal mass measuring 15 centimeter and 16 centimeter respectively, together with involvement of parotid glands, lungs, stomach, and spleen. The impression: our patient had presented in a very poor shape. The ABC subtype as such carries a poor prognosis. On top of that, he had a very high tumor burden, a lot of comorbidities, and poor performance status, amounting to that he may not survive at all. Frontline selection, moving beyond standard R-CHOP, is the title of this slide. So this gentleman was further investigated and treated for his lung infection, which was due to Klebsiella pneumonia. Fortunately, he stabilized. We gave him prephase with steroids, vincristine, G-CSF, and 1 dose of rituximab. The case was discussed in the tumor board, and it was decided to treat him aggressively because there was no other way to save him. This was because he was ABC subtype, he had an advanced stage. So we decided to bypass the so-called standard of care R-CHOP and treat him straight away with pola-R-CHP upfront to leverage the targeted antibody drug conjugate synergy when it matters the most. We'll come back to this statement a little later on, but the ADC polatuzumab is a wonderful addition to R-CHOP, replacing the vincristine. Our goal for this aggressive treatment was to achieve the maximum initial cytoreduction so that the disease does not progress with the inferior treatment. So that's the modified pola-R-CHP, in which you can see that pola, which is the ADC, replaces vincristine, which does not exist here. That's rituximab, cyclophosphamide, doxan, prednisolone. While the standard until pola-R-CHP came in the horizon was R-CHOP, where vincristine existed, pola didn't exist. And you have the rest the same: rituximab, cyclophosphamide, doxo, and prednisolone. So a word about pola and the mechanism of action. The target, CD1779B, is ubiquitously expressed on the surface membrane of mature B-cell lymphomas. The elegance of Pola lies in its precision. Replacing vincristine with Pola allows us to deliver a far more potent anti-microtubule agent, MMAE, monomethyl auristatin E, directly into the lymphoma cells. So the drug here is MMAE, and the job done by Pola is exactly because it is against CD79B, is to selectively take the MMAE, the payload, to a cell which is positive for CD79B and which fortunately is ubiquitously present on the mature B-cell lymphomas. The vincristine is the drug which is substituted because otherwise there will be severe neurotoxicity. The released MMAE diffuses into the surrounding tissue to some extent, as a result of which there is a killing of the neighboring tumor cell as well. At the same time, because the drug selectively binds to the CD79B, it minimizes the collateral damage to the healthy tissue. Addition of Pola to R-CHP is synergistic. It complements the rituximab-mediated ADCC and also the CHP chemotherapy. The treatment journey and navigating the storm. It's the title of my next slide. With his tumor load, it was worth giving rasburicase to him, and we did that before the first cycle. Despite all this, the journey was a little arduous. The storm had to be navigated, and we achieved that. In both cycle 1 and 2, he developed transient grade 3 neutropenia, which we managed with GCSF. During cycle 3-4, he had intercurrent febrile neutropenia, needing brief hospitalization and treatment with broad-spectrum antibiotics and antifungals. And we did that. And during the last 2 cycles, he developed manageable grade 1 peripheral neuropathy, but did not amount to any reduction in the dose as it was grade 1. Full planned dose could be delivered during all the 6 cycles of Pola R-CHP. And we are, I would say, proud of our guts to have done that. The turning point, the deep metabolic response. We were delighted to see that the interim PET-CT scan after cycle 3 showed a dramatic, that is over 90% reduction in the tumor volume. And the glory was the EOT PET scan, the end of the treatment PET scan showed Deauville score 1, that is complete metabolic remission. His blood counts normalized, his organ function totally reversed and became normal. ECOG performance status by the end of the treatment had dramatically moved from 3 down to 0. At the end of the therapy, the results were stunning. A patient who could barely sit up achieved a Deauville 1 response, that is complete metabolic response, and his performance status became ECOG 0. That is an aha moment. That's his PET, which I showed you in the beginning, and that's it PET EOT. There's nothing at all visible anywhere. That's the brain, that's the bladder. He's finished about a year after his treatment. He has sustained his complete metabolic response because the fear was that he may relapse. Though with Pola R-CHP, we were a bit more confident that the chance of his relapse will be small. So far, so good. His performance status has remained excellent. He has returned to the full-time work. He does regular physical exercises and he swims almost daily. His peripheral neuropathy has completely resolved. Immune reconstruction was also complete and his IgG level returned to normal. And there were no further recurrent opportunistic infections. So it's almost about a year. He is not only surviving, he has his life back, and that too entirely. Translating the case, the POLARIX landmark trial data. The POLARIX trial design, it is a phase 3 randomized trial comparing Pola R-CHP against R-CHOP. progression-free survival benefit is tremendous. 27% reduction in the risk of disease progression, disease relapse, or death, with a hazard ratio of 0.73. So that amounts to 27% reduction. Our patient success reflects the data from the 5-year follow-up of Polarix trial, which is published in JCO already. So we have now a very long follow-up. As you know, DLBCL patients relapse in early 1 or 2 years of their post-treatment. So once you got a 5-year follow-up, the progression-free survival of 5 years is equal to cure. The 5-year progression-free survival is 65% with Pola-R-CHP versus 60% with R-CHOP, with a hazard ratio of 0.77. From the angle of safety, the high-grade adverse events were comparable in the two arms. So Pola-R-CHP significantly reduces the hazard of progression. Again, recapitulating, by giving Pola-R-CHP, you reduce the risk of progression, relapse, or death by 27%. So this slide has 3 components. One is how R-CHOP is replaced with Pola-R-CHP. Second is how you decide the IPI. And this trial was conducted and included patients who had IPI of minimum 2, right up to 5. And this shows you in the form of histogram how the progression-free survival at 2 years was 76% versus 70%. Now this is 5 years data. So Pola-R-CHP, you got progression-free survival of 65% versus R-CHOP 59% with hazard ratio 0.77. And we're talking about now 5-year data. Similarly, overall survival with Pola-R-CHP 82 versus R-CHOP 79. If you look at the adverse effect profile, the lighter color and the dark color. Lighter is grade 1, 2, darker is grade 3, 4. So if you look at the two arms, R-CHOP and Poly-R-CHP, there is no difference whatsoever. So there is no more toxicity by adding this important drug to our protocol, whether it is peripheral neuropathy, whether it's a GI symptom, it's fatigue, alopecia, or mucositis. Conquering the ABC subtype and closing the prognostic gap is the next title. We all know that ABC subtype has been our Achilles heel. This subtype underperforms. And if you use classical R-CHOP, the outcome is bad. Pola-R-CHOP, or Pola-R-CHP rather, has pronounced benefits in the ABC phenotype. The subgroup analysis, which has been now repeatedly published, shows a marked risk reduction, especially in the ABC phenotype. Pola-R-CHP overcomes the intrinsic chemotherapy resistance mechanisms, which are typical of ABC subtype of DLBCL. It fundamentally bridges this prognostic gap, offering these high-risk patients a very durable and curable frontline response. So friends, it's very important that when you have an ABC subtype of DLBCL, the poor outcome of R-CHOP can be replaced with excellent outcome with Pola-R-CHP. I already mentioned about the safety and the tolerability profile, but that's the summary here. Low discontinuation rate, which emphasizes the excellent real-world tolerability. Anxiety regarding toxicity are debulked by the trial data as well as the clinical practice. The grade 3-4 neutropenia rates are manageable by routine prophylactic growth factor, which is mandatory. Peripheral neuropathy, similar incidence across the arms. Replacing vincristine keeps the neurotoxicity in check. And there was absence of severe cardiotoxicity or any other unexpected long-term organ damage. The big picture. value of frontline cure. I can't overemphasize the value of frontline cure. In oncology, we know it very well. So curing the patient upfront is the most cost-effective way and the compassionate path to follow. Frontline failure means you'll end up with aggressive salvage therapies, where most of the high-risk patients are lost. Over 70% of relapsed high-risk ABC DLBCL patients fail with whatever salvage regimens you may have in your armamentarium. Upfront cure reduces the financial cost because significantly less number of patients will require CAR-T or bispecifics or transplant. Fewer subsequent lines of therapy means less time spent in the hospital. And it also means much lesser toxicity and higher attrition, which are associated when relapses occur. So if your patient relapses, which would happen left and right with R-CHOP, if you give it for the ABC subtype of DLBCL, you will end up using CAR-T or bispecifics or ADCs or other targeted therapies, many of which you don't even have in your country. And all this is very expensive. All this is also extremely toxic. So, living a peaceful life, hope for a cure, is curing the patient in the first line. Why Pola-R-CHP must be your new frontline standard? We can no longer justify R-CHOP for every patient. The blind treatment of giving R-CHOP to all DLBCL is disseminated. For individuals who present with aggressive disease, high IPI, that is 2 to 5, ABC subtype, Pola-R-CHP has become the baseline choice. And if you don't use it, you are giving an inferior treatment. It provides the maximum benefit where it is needed the most, like the proband that I showed you. It replaces the decades-old benchmark. It's about 40 years after which this particular protocol has shown its benefit. Pola-R-CHP has statistically confirmed superior progression-free survival. It can be delivered very safely in the community by community oncologists, and we do it left and right in small centers. Conclusion: curing more, losing fewer. Our patient with slim odds is now living a normal life. Remember, he was transferred from Siliguri by air ambulance, bedridden. This is because of the targeted frontline intervention. Moving from the empiric R-CHOP to a precise biomarker-informed immunotherapy combination helped. It prevented early relapses, and that increases the DLBCL cure rates. Our patient survival is clear evidence of this huge clinical progress that has occurred in the last 5 years. By optimizing frontline treatment with tools like Pola-based treatment, we have moved closer to the cure. Well, thank you for allowing me to present this case. And now I'm going to take you to a podcast that I had with my one colleague from Guwahati. The colleague is not present here, so I'm going to do the job of both question and answer. There are some very interesting questions which you may be having in your mind. If not A, B, C, somebody will have these questions. I'm going to answer all of them to the best of my capacity. Why does ABC subtype derive a more pronounced benefit from Pola than the GCB subtype? The ABC subtype is highly dependent on chronic active B cell receptor, the BCR signaling. Targeting CD79B, which in turn is an essential component of BCR complex, you are disrupting this oncogenic pathway. That's why ABC very specifically benefits by using Pola. Question: what does the 5-year Polarix data show specifically for the ABC subtype of DLBCL? Answer. The 5-year data shows a striking sustained benefit in the molecularly defined ABC subset, with 25% absolute improvement in progression-free survival and a 15% advantage of overall survival than the standard R-CHOP. Question. While selecting Pola-R-CHP as the treatment protocol, can the Hans algorithm reliably substitute the gene expression profiling? You all know that the gene expression profiling is not available to you and me and is not in clinical practice anywhere in the world. So we all, whether US, Canada, Europe or Australia, we all rely on the Hans algorithm. So answer, in routine practice, yes. However, yes, gene expression profile is the gold standard. Hans algorithm does misclassify about 20% of cell of origin cases compared to the digital RNA assay. But that's the best you have in clinical practice all over the world. And the results that have been presented to you is using the Hans algorithm. Question. Should Pola-R-CHP be used if the patient presents with an advanced GCB subtype? So subtype is GCB and the patient has got a ghastly disease very advanced. Will you use Pola-R-CHP? So well, if you look at the regulatory approval from US FDA or from Europe, it is for both ABC and GCB subtype. And that also applies to India with IPI 225. 2026 consensus, however, regulatory approval is different, consensus is different. Consensus is that Pola-R-CHP gives no clinically meaningful progression-free survival or overall survival advantage over R-CHP in a true GCB patient. Okay, so true GCB patient, probably you don't have to waste your money on Pola. How does Pola-R-CHP perform in double expressor lymphoma within the ABC spectrum? Answer, it maintains the clear edge. Both double expressor status and MYC-BCL2 co-expression show favorable long-term survival with Pola-R-CHP as compared to R-CHOP. So double expression in ABC subtype, Pola is the way to go. What is the primary takeaway from the 5-year Polarix update published in late 2025? The frontline progression-free survival benefit is durable and sustained for 5 years. The 5-year PFS stands at 64.9 for Pola and 59.1% for R-CHOP. The hazard ratio 0.77. Question. Is there a statistically significant overall survival benefit across the general intent to treat population at 5 years? Answer, no. While there is a positive trend favoring Pola-R-CHP, 82.3% versus 79.5%, the statistical difference remains non-significant. Now, why is this so? This is because highly effective subsequent salvage lines are available. Now, that's the statement from the Western world, because their patient, if the first line fails, can easily get into the CAR T or bispecifics or autologous transplant. Now, what happens to India? Or what happens to the most of the world, which is developing world? The effective subsequent salvage lines are not available, either because of the shortage of funds or because of the facilities. So this 82% versus 79% is vitiated because that overall survival is catching up because of the very widely prevalent use of these second salvage therapies, which we are handicapped in. Well, given the lack of general OS significance, what justifies the frontline use of Pola-R-CHP? Well, the 23% reduction in the risk of progression or death means fewer patients will experience early relapse, avoiding the physical trauma, psychological trauma, and the financial burden of moving to CAR T bispecific or ASCT, which you and me all agree is not available to 90% of our population. Does Pola-R-CHP completely replace the need for vincristine? Yes, Pola entirely replaces vincristine. The O in R-CHOP, this mitigates the overlapping additive neurotoxicity. Should an advanced stage ABC DLBCL patient, advanced stage 3-4, but having an IPI score of 0-1, should you treat this patient with Pola-R-CHP? The answer is no. The POLARIX trial and the current NCCN guidelines restrict its use to IPI 2+. Low-risk patients continue to show excellent outcome with standard R-CHOP, and you don't have to move to Pola. Does Pola-R-CHP increase the long-term risk of peripheral neuropathy as against R-CHOP is another worry of our colleagues. So at 5 years, the answer is big no. At 5 years, any grade peripheral neuropathy rates are identical. 50% with Pola-R-CHP, 52% with R-CHOP. And all this is usually grade 1-2. And it is almost completely reversible. Question. What's the most common grade 3-4 hematological toxicity with Pola-R-CHP? Well, the commonest is neutropenia, occurring in 43.8%. However, its incidence is comparable to R-CHOP, and it does not result in high rate of febrile neutropenia. Is routine GCSF prophylaxis mandated while giving Pola-R-CHP? Answer is yes. Due to the high risk of severe neutropenia, primary GCSF prophylaxis is strictly recommended across all the 6 cycles. How does Pola-R-CHP fare in elderly people aged above 80 in the real-world cohorts? It is highly effective, but requires caution. Real-world 25-26 data shows that attenuated dosing of Pola-R-CHP, similar to our mini-chip which we do, is required so that the risk of infection does not go up. For a patient in continuous metabolic remission at 1 year, is routine surveillance imaging indicated? The answer is no. Current 26 guidelines recommend that routine surveillance CT PET scan in asymptomatic DLBCL who is in CMR not required because it does not lead to improved overall survival and it increases the radiation exposure because there is a CT in CT PET. If this patient relapses after 1 year of CMR, are they considered as primary refractory? No. A relapse after 12 months signifies chemosensitive disease. Primary refractory or early relapse is defined as a disease which must progress within 12 months of finishing the frontline therapy. What salvage options exist in 2026 for an ABC DLBCL patient who has relapsed after using frontline Pola-R-CHP? Well, the standard second-line treatment shifts immediately towards CD19 CAR-T cell therapy. And if that's not possible, platinum-based salvage followed by ASCT. Can Pola be reused in the relapse setting when you have already used it in the front line? The answer is no. Rechallenging with the same antibody drug conjugate should be avoided because of the potential tumor antigen escape, that is downregulation of CD79B or permanent clone resistance. So you probably don't get the benefit of using Pola again in relapse setting if it was already used upfront. What emerging frontline combinations are threatening to rival Pola-R-CHP in 2026? Is there a competition for Pola-R-CHP? Yes, there is phase 3 data coming from TAFA, Len, R-CHOP. That is tafasitamab, lenalidomide with R-CHOP. This trial has shown fierce competition, particularly as a highly effective target for the GCB subtype where Pola underperforms. So if you have a GCB subtype, we know that Pola is not a great drug there because the mechanism of action of Pola requires ABC. TAFA Len R-CHOP gives fascinating result. Mind you, tafasitamab we do not have in our country. ctDNA, circulating tumor ctDNA molecular monitoring. Is it a standard practice today in 2026? It is rapidly transitioning from research to clinical management. MRD detection by ctDNA is highly predictive of imminent radiological relapse, though escalating therapy based purely on ctDNA remains under trial validation. So even if ctDNA is available to you, at the moment you do not escalate the therapy, it's under trial. What is the standard POLA-based regimen used in the relapsed setting for DLBCL? So the standard regulatory approved regimen is POLA-BR, where POLA is combined with bendamustine and rituximab. Can POLA-BR be used in a patient who has received frontline POLA-R-CHP? We have answered this question. No. POLA-BR is reserved for patients who are POLA-naive, as tumor cell often downregulates the CD79B or develop resistance after frontline exposure. What is the primary role of POLA-BR in a patient who is transplant ineligible? Well, it serves as a very effective palliative or even as a bridge therapy, offering very rapid disease control with an overall response rate of almost 45%. That is 1 out of 2 patients. How does the incidence of peripheral neuropathy differ while using POLA in the relapse setting versus frontline setting? Well, it is significantly higher and more in the relapse setting because you have used vincristine upfront. So you are giving now 2 toxic drugs to the peripheral nerve. Can POLA-BR be used as a bridging therapy immediately prior to CAR-T? Well, yes, it can be. It is frequently used for rapid cytoreduction, but Benda must be timed very carefully or not used at all, because Benda leads to prolonged T-cell lymphopenia, which will affect the CAR-T manufacturing. Is POLA-R-CHP approved and effective for frontline high-grade B-cell lymphoma, the HGBL? Yes, POLA-R-CHP is FDA approved for newly diagnosed HGBL, including double hit and triple hit, offering a significant PFS advantage over standard R-CHOP, and this is new. Does adding POLA to Benda-R improves outcome in relapse refractory follicular lymphoma? The answer is no. Randomized data from this trial extension demonstrated that adding POLA to BR does not have significant efficacy benefit over BR alone in relapse refractory follicular lymphoma, and it adds to the hematological toxicity. So relapse follicular lymphoma, no. What is the emerging role of POLA in relapse refractory mantle cell lymphoma? Well, this is a fascinating subject. It's an active area of off-label exploration. CD79B is very heavily expressed on mantle cell lymphoma. So combining POLA with bispecific antibody is showing great promise as a salvage activity in post-BTK inhibitor failure. Can POLA-based regimen be utilized for primary CNS lymphoma? This question has already been put up in the chat box. I didn't answer at that time because this question was coming up. The answer is no. POLA-vedotin is a very large antibody drug conjugate, and it does not efficiently cross the BBB. Therefore, it is grossly limited in its utility in active primary CNS lymphoma or even metastatic CNS lymphoma. Is there a role for POLA in CLL or small lymphocytic lymphoma? No. Unlike aggressive B-cell lymphoma, CLL, SLL cells typically express very low level of CD19B, rendering POLA-targeted therapy largely ineffective as against standard BTK inhibitor or BCL2 inhibitors. Is routine CD79B flow cytometry testing necessary before you use POLA in classical DLBCL? The answer is no. Classical DLBCL exhibits universal high-level
CD79B, and therefore pre-treatment screening is redundant and not required in the classical DLBCL. Is frontline pola-R-CHP standard of care or FDA approved for newly diagnosed primary mediastinal B-cell lymphoma? No. Primary mediastinal B-cell lymphoma patients are explicitly excluded from the pivotal phase 3 POLARIX trial. It is not the standard frontline choice. And the reason is CD79B expression on PMBL is extremely variable. Is pola-R-CHP replacing DAR-EPOCH for double and triple hit lymphoma? And that is a fascinating news I give you. Yes, the field is actively shifting. While DAR-EPOCH remains the established standard due to the retrospective multicenter historical survival data, pola-R-CHP is increasingly preferred as an equivalent, less toxic OPD option for patients who cannot tolerate a continuous infusion regimen, which is hospital-based as well. Exploratory analysis from POLARIX trial show that patients with high-grade B-cell lymphoma achieve durable, favorable 5-year progression-free survival and overall survival with pola. DAR-EPOCH mandates continuous infusion and intensive dose escalation, resulting in very severe prolonged neutropenia, mucositis, hospitalization, and all these are bypassed by outpatient-friendly pola-R-CHP. The caveats, however, are true double-hit lymphomas are overwhelmingly GCB subtype, while pola-R-CHP margins over R-CHOP are very slim in GCB subtype. For rare ABC subtype double-hit and double expressor, pola-R-CHOP provides no doubt a clear-cut survival advantage. Double-hit lymphoma carry an exceptionally high risk of CNS progression. DAR-EPOCH goes there. It crosses the blood-brain barrier. While, as we mentioned, the pola-based protocol, it does not go to the blood-brain barrier. Which T-cell engaging bispecific antibodies are preferred for relapsed DLBCL patient following pola-R-CHP? Well, epcoritamab subcutaneously, glofitamab intravenously are the preferred CD20, CD3 bispecific, showing high response rate in post-pola relapses. Can bispecific antibody be used as a bridge to CAR T, or do they cause T-cell exhaustion? They can be used as a bridge, but brief exposure is the key. If you use them in a prolonged way, they do cause T-cell exhaustion and subsequently impair the CAR T-cell manufacturing and expansion. Is a CD20 targeting bispecific effective if the patient relapses immediately after rituximab containing pola-R-CHP? Yes, despite recent rituximab exposure, CD20 expression is never completely lost at first relapse, and that allows your bispecifics to remain highly active. What is the optimal sequencing order between CAR T cell therapy and bispecific antibodies in 2026? Well, CAR T remains the preferred second-line standard for early relapses. That means relapses before 12 months, while bispecifics are ideally sequenced in the third-line setting or for patients who are ineligible for CAR T or do not have access to CAR T. What is the primary safety concern when initiating a bispecific antibody immediately after frontline regimen failure? Well, cytokine release syndrome and ICANS, which require step-up dosing and mandatory monitoring during cycle 1, has to be considered when you are using it very early in the phase of relapse refractory patients. Well, thank you so much. That's all what I had for presentation. We can stop sharing the slide deck, and we have about 13 minutes left. If there are... Let me see if there's something in the chat box. What is preferred for CNS prophylaxis with pola-R-CHP? CNS IPS score 3, high-dose methotrexate or intrathecal methotrexate with cytarabine. When we talk about DLBCL, the CNS disease is parenchymal disease and not meningeal. And therefore, high-dose methotrexate is far superior to intrathecal methotrexate, which does not take care of parenchymal disease.
The next question is, infection and neutropenia are significantly more in my experience. Any special prophylaxis apart from primary GCS? Not really. I mean, the data could be individually different, but as we just showed you, the overall incidence of infection and its grade with R-CHOP and pola-R-CHP is not different at all in the POLARIX trial. So that was in the chat box. Now, if somebody has any question from here, at 7:30, we'll be starting with the second lecture. If somebody wants to share your experience, because by now pola-R-CHP is quite popular regimen in India. Almost everybody has used in large number of patients.
So there is one more question in the chat box.
I'll just check. If 2 doses of R-CHOP are given, can further 4 doses be pola-CHP, or should I give 6 pola? So I can't give a scientific answer to that, but sometimes you do a very early interim PET scan. Now, if you do that PET scan, the reason for not doing PET scan is that you do not know what action to take at that stage, because number of these patients get complete metabolic response at the end of 6 cycles. So when you use 2 cycles of R-CHOP, if the reason for that was other than science, say like finance, or whatever reason it may be, patient moved from one oncologist to another oncologist, so on. So if you think that originally the disease was the type who will tremendously benefit from pola-R-CHP, like ABC subtype, aggressive staging, fulfilling all the criteria, then you can probably in practice do it, because you will be concerned that R-CHOP may result into very high failure rate. Can we use pola-R-CHP in GCB subtype of DLBCL, I suppose you're asking? So as I said, the NCCN guideline, the US FDA approval exists for GCB. That came 5 years ago. The 2026 consensus is that it is not more effective than R-CHOP for GCB subtype, so use it for ABC. Having said that, that caveat is there that we are using Hans algorithm. And in Hans algorithm, there is a 20% fallacy of differentiating GCB ABC subtype. Should I give only 4 pola-CHP, or should continue 2 more pola alone, making it 6 pola? Well, not really. These are aggressive diseases. Your IPI was high. You got ABC subtype. In these kind of patients, giving 4 pola-CHP and then reducing it to pola alone is not justified. I mean, you're going with, I think, Hodgkin disease and all that. No, that cannot be applied here. Excellent talk, sir. Thank you. Have good experience with pola-R-CHP and haven't faced serious issues with infection. I agree with you. I mean, if you are careful from all the angle with antimicrobial prophylaxis and using GCSF liberally, most of the patients, you do not land up into life-threatening problem. There may be short neutropenic fever or occasional sepsis needing hospitalization, but no, nothing worse than R-CHOP. Dr. Tejaswini. Your voice is breaking. Your voice is breaking up. So we couldn't hear Tejaswini. Maybe she'll put it in the chat box.
Meanwhile, Dr. Bharat Patodia has put a question. This question is continuation of 2 R-CHOP followed by 4 pola R-CHIP or 4 pola chip followed by another 2 pola, making 6 pola in total. Well, you can do all kind of permutation combinations. That is okay. But then you are giving almost 8 cycles. GCB patients with IPI 4 or 5. Your recommendation. We discussed this in the QA. So if you have got a IPI 4-5, but it is GCB subtype, probably you are not justified in using polar chip. Another question is it possible to use polar R chip in secondary CNS DLBCL with high-dose methotrexate? How do we incorporate the high-dose methotrexate in this setting? So first of all, pola is a large molecule. It does not cross the blood-brain barrier even when it is broken or inflamed or diseased. So for CNS disease, pola is not recommended. That's number one. Number two, when you got a CNS involvement, yes, you got to use the drugs which penetrate the CNS. So high-dose methotrexate based protocol will get priority. Cytosine albinoside, dexamethasone, high-dose methotrexate, any protocol that you're used to, which has got these drugs, are superior to anything else. Very good outcome for 1 or 2 patients we used, but at follow-up, if they were clinically well, is it necessary to repeat PET scan frequently? Absolutely not. You don't have to do the PET scan. As was a question put up, surveillance PET scan are required only when you are clinically suspecting a disease. So they are not required whatsoever as a routine, because you allow some radiation exposure to take place, and the outcome of this patient by monitoring with PET scan is not superior to those who have been followed up clinically. So yes, that was Tejaswini's question. So no surveillance PET scan for DLBCL. We have another few minutes. How many of us are successfully salvaging patients of ABC subtype of DLBCL who have relapsed? Access to CAR-T, access to bispecific, if there are late relapses, access to autologous transplant, successful salvage chemotherapy, and then finally not relapsing third time, so getting cured. Any experience? Because my experience is pathetic. There is no very great availability of bispecific. Glofitamab is available, but you have to import it through these guys who import it for you. CAR-T, yes, those who can afford and those who have a facility to go and stay at the city where CAR-T is available, yes, it's available. And those who have delayed relapses, yes, if they're chemosensitive, they can undergo autologous transplant. All this requires money. All this requires infrastructure. All this requires institutional care for most of the patients. Probably not many have too many cases of this type. Most of them are very disheartened also. You can see the agony when the patient relapses. Many of them just quit. As a bridge to CAR, is bridge to CAR-T must? And post CAR-T, how many doses of Polivy can be given? So as a bridge to CAR-T, yes, pola-based treatment has been used. As I mentioned, the bendamustine should be avoided or used very carefully. So number of times people have used, and I have used pola with rituximab. I've also used with glofitamab. So you can use these drugs as a bridge to CAR-T. You want to reduce the tumor. And post CAR T, how many polypi? I don't think I have an answer to this. If anybody has a scientific answer, please reply. I have no idea whatsoever after CAR T, the use of polypi. If you are talking about bispecifics in combination with polypi, that can be done. CAR T failed using bispecific, and there if you want to link it up with polypi, okay, that has been done. How many cycles ideal for bridging for CAR T? Well, it's just a question of when your CAR T product is going to be ready, that's all. The moment the CAR T product is ready, 20 days, 25 days, 28 days, 30 days, till that time you are trying to bridge. I'm just waiting for it to be 7:30, and Dr. Kamdar will take over for the wonderful lecture that we are all waiting for. Any significance of other molecular classification, lymphogen, DLB class, dark zone? I'm sure. Only thing I may not be able to answer this question to you that in there, which subgroup to use POLA. So in that, everywhere when there is ABC, then as I explained the mechanism of action, the BCR-ABL pathway, which is disrupted by POLA. So that's the answer I have. But in remaining all these classifications, POLA versus R-CHOP, if there is any data available, I am not personally aware of it. Possibly there may be. Sorry, I'm late here. How is combined with lenalidomide, POLA R2 in DLBCL? POLA rituximab with lenalidomide. So I think upfront, there is no data. For relapse setting, there may be some data. Personally, no idea. All these couple of questions which are coming up, we can put to Dr. Kamdar also and ask her after her talk, of course, which will soon begin. Yeah, Dr. Manali has joined. So Can I ask my slide deck to introduce her?
Yeah.
So, well, friends, now we move on to the second talk of the day. And as was stated, speaker is Dr. Manali Kamdar. She has been our guest speaker in person and online at multiple occasions during last 5 to 6 years. To introduce her, she obtained her medical degree from Mumbai, India, and subsequently completed a residency in internal medicine and a fellowship in hematology and oncology at the East Carolina University of Greenville, North Carolina. She then completed another fellowship in lymphoid malignancies and bone marrow transplantation at Stanford University. Subspecializing in lymphomas appealed to her because of the clinical heterogeneity of each subtype, scientifically stimulating biology, opportunity to tailor therapeutics, and the endless possibilities of new drug development. Currently, she is Associate Professor of Medicine at the University of Colorado School of Medicine and serves as the Clinical Director of the Lymphoma Program. Her clinical and research interests include B-cell lymphomas, particularly refractory DLBCL, mantle cell lymphoma, and other indolent lymphomas. In addition to seeing patients with lymphoma in the clinic, her research involves conducting clinical trials of novel drugs, including immunotherapy and combination in these diseases. She's had an opportunity to serve in organizations at the national level. This included working with the National Comprehensive Cancer Network Guideline Committee and Southwest Oncology Group Lymphoma Committee, where she served as a cadre member of the CLL and lymphoma working groups, respectively. Her goal is to develop nuanced approaches to personalized medicine in lymphoid malignancies, and she is currently collaborating with several clinical as well as laboratory-based investigators in the United States. Her eventual hope is to make these fascinating discoveries efficacious, durable, and affordable so that they have a far-reaching impact on patients everywhere. Today, she is speaking to us on clinically pertinent advances in therapies of B-cell lymphoma. Thank you. And we hand over the platform to Dr. Manali Kamdar.
Dr. Agarwal, I'm actually having a little bit of a problem signing in. So if you could just give me 1 minute.
Please take your time.
sorry for the delay in getting our talk started for today, but the goal for today's talk is to really highlight some of the clinical pertinent advances in B-cell lymphoma management. Moving forward, the most common B-cell lymphoma is diffuse large B-cell lymphoma. As you know, it makes up for about 30%. In the United States, there are a total of 50,000 patients that get diagnosed with diffuse large B-cell lymphoma every single year. As a result, the burden of the problem continues to increase as we improve not just the prevalence, but also the overall outcomes of patients. So what has really changed over the last several years, especially in the last decade of giving treatments to patients with B-cell lymphoma? So with that in mind, I think we need to first highlight that the biggest change comes in the form of the WHO classification. There used to be, in 2016, a requirement to report diffuse large B-cell lymphoma in two forms. We absolutely got a mandate from the WHO that if we are reporting out a histology as DLBCL, we need to figure out if this is germinal center or non-germinal center. When you talk about germinal center versus ABC, you're really talking about gene expression profiling, which nobody can do in clinic because the assay is not standardized. We do IHC, which I will talk about soon. In 2022, there were several additions that were made that basically helped us include more patients with B-cell lymphoma. For example, the biggest clinical advance change in definition came from the verbiage of nodular lymphocytic predominant. What used to be Hodgkin lymphoma is now incorporated under B-cell non-Hodgkin lymphoma. So NLPL is an entity that has been moved to non-Hodgkin lymphoma, and the idea behind it is to primarily be able to include patients on clinical trials, because this subtype ends up otherwise being quite an unmet need and doesn't really belong in any other clinical trial classification. The other advance came in the form of understanding what is high-grade B-cell lymphoma. A lot of times we used to use the verbiage double hit, triple hit. Now we use high-grade B-cell lymphoma and then specify what the FISH study shows us. If the FISH study says that the MYC gene rearrangement is positive, then we look for either BCL2 or BCL6. If we have MYC and BCL2 positive, that is a double hit. And in the WHO classification, MYC and BCL6 is no longer recognized as double hit, but in the ICC classification, MYC and BCL6 is still recognized as double hit. The verbiage triple hit has been taken away because whether a patient has double hit or triple hit, they actually uniformly fare worse. With regards to the distinction of BCL2 and BCL6, it's primarily highlighted that way because MYC with BCL2 partner does worse than MYC with BCL6 partner. There's also an entity that used to be called DLBCL, somewhere mixed between Burkitt lymphoma and high grade. Now that entity, if does not have the c-MYC gene rearrangement, is actually NOS. So cell of origin. I think a lot will be made in terms of cell of origin. It used to be only prognostic, but it's getting to be therapeutic and predictive quite soon. So previously we knew DLBCL was not just one disease, it's divided into two different types based on gene expression profiling. We have the germinal center phenotype and the ABC phenotype. You can see the blue curve fares inferior to the red curve. So that way, multiple clinical trials got designed. Nobody had the ability to actually do GC versus ABC. The best we have come close to is an IHC algorithm that your hematopathologist stain in the lab. So this is the Hans algorithm. It starts with CD10, BCL6, MUM1, as you can see, and that can uniformly figure out GCB versus non-GCB. But it does not actually capture 100% of the differentiation. The concordance rate is only 70%. So now moving on to how our science is evolving, you can see that there is not just two subtypes of diffuse large B-cell lymphoma, but now we actually have 5 different subtypes of diffuse large B-cell lymphoma based on which lab that expression profiling, which is molecular profiling, came from. So GC can further be divided into multiple targeted pathways. It can either be called the lymph-gen classification or the DLB cluster. The DLB cluster includes 5, C1 through C5. And why is it important? Because each of these have unique ability to actually intercolate and be able to eventually be druggable. So, for example, within the National Cancer Institute intergroup platforms, we are actually developing clinical trials looking at molecular profiling, and each of these subtypes are going to go through randomized phase 3 studies. So, for example, MCD or C5 has a randomized phase 3 study that is currently being planned where it gets randomized to R-CHOP or R-CHOP-POLA versus R-CHOP plus that druggable target, which is a BTK pathway. So it could be ibrutinib or acalabrutinib. So there is going to be a sea change of what is going to happen in the near term. Let's now talk about standard of care in diffuse large B-cell management. In terms of what truly changed outcomes, it was R-CHOP. R-CHOP was now 3 decades ago. R-CHOP made people survive longer. 60% of patients have a cure with R-CHOP. And then after that, there were several trials that actually either intensified, gave it frequently, added a targeted inhibitor, but nothing really panned out to be a positive study. The only first positive study was the POLARIX study. Interestingly, it has generated a lot of debate despite it being meeting its primary endpoint. So I'll go over POLARIX in a little more depth because I do know that polatuzumab is available for our patients in India. POLARIX was a pola-R-CHOP versus R-CHOP study. It was in advanced stage patients with an IPI of 2 and over. Primary endpoint, investigator assessed PFS. In terms of demographics, they were very equally matched. With regards to cell of origin, it was one of the exploratory endpoints, but it was done with gene expression profiling. There was no IHC done prospectively on this study. Now, the good news is that the progression-free survival was significantly better, statistically significant with pola-R-CHP compared to R-CHOP. We now are able to figure out what happens at 2 years, and it's a surrogate for what a patient may or may not be able to get cured. So if people typically end up being in a remission after 2 years of receiving frontline chemo, it's actually quite rare for them to have a late relapse. So with that in mind, uniformly, if you see majority of the frontline DLBCL studies actually incorporate a 2-year endpoint. So with that in mind, at a median follow-up of over 2 years, the 2-year progression-free survival for pola-R-CHP was statistically significant at 77% versus 70%. The 5-year follow-up was also published, and here there's a dip in about 10%, but still remains statistically significant. So what are we doing with pola-R-CHP? We are probably giving our patients a 5% chance of a benefit to be in progression-free remission. In terms of overall survival, there is no difference. So there are many investigators who may say, what's the point of it all if you cannot improve overall survival? But I do believe that in DLBCL, we are changing the biology of the disease. We're changing the biology because we have downstream treatments. If you have a CAR T, if you have a bispecific T-cell engager that can actually prolong your remission, it will reflect in not being able to demonstrate an overall survival. I think my biggest takeaway from a POLARIX standpoint is actually its safety summary. The safety profiles were near identical. I recognize that polatuzumab is economically more burdensome, but at the same time, if you look at the safety profile, it is actually quite equivalent. There may be a little bit more diarrhea, but in terms of discontinuation rate, in terms of serious adverse events, these are not really different between the two groups. So Then comes the subgroup analysis, which generates the highest amount of debate in 2025 and onwards. We have 800 patients. This is a subgroup analysis. It's usually underpowered because it's a subset analysis. You can see the majority of patients benefit. IPI 3s, male, over 60, people with bulky disease. Now let's look at cell of origin. If you look at cell of origin, germinal center phenotype seems to end up with a negative benefit. So there is really no difference between R-CHOP and R-CHIP Pola. But if you look at ABC, there is a benefit. If you look at people who don't have this ability to do subgroup differentiation, there is also a benefit in those subgroups. So why does it matter? Because there is a huge impetus here to figure out who really benefits from polatuzumab. And there have been multiple meta-analyses of polatuzumab-based clinical trials which have shown that Pola primarily works in the ABC phenotype, probably in the non-GC. But remember, non-GC and GC by IHC is not 100% accurate. More so, if you look at the genetic signature of germinal center, there is a unique type called the dark zone signature. And if you look at the dark zone signature, which we have no ability to do in clinics here or anywhere in the world, but dark zone signature positive benefit from Pola R-CHIP significantly than dark zone signature GCB with R-CHOP. So my takeaways from Polarix are, if a patient is able to afford polatuzumab, but the patient has advanced stage disease, IPI2, I prefer Pola R-CHIP in GCB as well as non-GCB because that's what I can do in my clinic. Because I don't know if I'm taking away the GCBs and not giving them polatuzumab if I'm not enriching them for the dark zone signature. Now let's talk about what really happened at ASCO. At ASCO, a big splash came in the form of frontMIND study. This was also a phase 3 randomized study where the control arm was R-CHOP, not R-CHIP Pola, but it was R-CHOP plus TAFA plus lenalidomide. Tafasitamab is an anti-CD19 antibody, and this was primarily delivered in a very high-risk IPI setting of 3 to 5. And the bottom line is that it met its primary endpoint. TAFA len R-CHOP is better than R-CHOP. The 3-year PFS, identical to Polarix, 67% versus 60%. So the big question is, where would I use Tafalen? Why would I use Tafalen? I think some things definitely caught my attention during this talk. Number one, grade 3 and higher treatment emergent adverse events were 10% higher with Tafalen R-CHOP. Lenalidomide is actually not an easy pill to swallow. It has a lot of side effects. Some people sail through it, but majority will have diarrhea, neutropenia, fatigue in terms of to the point they can sometimes just be bedridden, and we do have to dose reduce. Renal function issues, the need for aspirin or Lovenox because there is a risk for DVT. So there is a lot of polypharmacy happening with Tafalen R-CHOP. I would be very interested to figure out an economic analysis between Polarix and Tafalen R-CHOP to figure out what actually makes the most economic sense. But what is heartening to see is there is no difference in the cell of origin, agnostic for Tafalen R-CHOP. So GC, non-GC doesn't matter. Now moving forward to why I would still prefer Polarix. I would still prefer Pola R-CHIP because with Tafalen, patients have to come to clinic 1/8/15 every 21 days to get the Tafalen. So it's quite cumbersome. There's a higher risk of febrile neutropenia. There's a higher risk of grade 3 or higher adverse events. So what is happening in the world of diffuse large B-cell lymphoma? A lot. Every single clinical trial is looking quite promising, and I think the biggest splash is going to come with bispecific T-cell engagers. As everybody knows here, CD20 bispecific T-cell engagers is an antibody with two prongs. One sits on the lymphoma cell with CD20, the other one recruits T-cell and basically causes cytotoxicity to the lymphoma cell. So there are multiple bispecific T-cell engagers that have been identified and approved. The one that we really like here are time limited CD20 platforms such as glofitamab and mosunetuzumab. So, as we know, for our frail, medically unfit patients with newly diagnosed diffuse large B-cell lymphoma, the standard of care is R-mini-CHOP. With R-mini-CHOP, the cure rate is only 40%. So we have a lot that we can do trying to improve upon the cure rates of R-mini-CHOP. So with that in mind, this was a study that was designed, which consists of rituximab, polatuzumab, and glofitamab. This is not chemo-free. This is chemo-light because polatuzumab is chemo. So with our PolaGlow, you can see that this was given in medically unfit patients. They could technically get a cycle of R-CHOP if needed, but overall, this was used for debulking. Initially, they opened this in one center and then opened this across Germany and Australia, and 80 patients were identified. Primary endpoint was 1-year PFS. You can see that there were significantly unfit patients, 91%, based on the simplified geriatric assessment. Overall response rate was a whopping 96%, and that was after cycle 2. After cycle 12, so glofitamab was given for 12 cycles, pola for 6 cycles. In terms of adverse events, they were very manageable. 80% finished treatment. Treatment was well tolerated. There was a low treatment-related mortality. And overall, this yielded a complete response rate of 81%. This complete response rate is actually quite similar to what we see with R-CHOP. So in terms of CRS and neurotoxicity, because it's a bispecific T-cell engager, cytokine release syndromes can happen, but all of them were low grade, 31%, grade 3, only 1. In terms of ICANS, I don't really believe that CD20 bispecific T-cell engagers cause true ICANS. It typically happens if patients get headaches. It gets reported ICANS. If someone has CRS and a very high grade fever, they will be disoriented. And then you get a point for the ICE score. And thus, overall, I do believe that ICANS is also reassuring. The one signal I will keep talking about is the signal of CD20 bispecific T-cell engagers with regards to infection. These constructs cause B-cell depletion. Infections are a function of that, primarily viral infections. It will be absolutely essential that we track patients who get CD20 bispecific T-cell engagers for infections and prophylax them with HSV prophylaxis and PJP prophylaxis. We also check for IgG, and if the IgG is less than 400, we typically give them IVIG. Now let's talk about the outcomes. It met its primary endpoint. The 1-year PFS with the R-mini-CHOP data was actually touching 50%. So if you extrapolate, cross-compare across clinical studies, the 1-year PFS is now 85%. So we're making huge progress, and there is a large phase 3 randomized study that is about to get launched comparing our PolaGlow to R-mini-CHOP. Very quickly, this might become the standard of care. Now let's move on to what else happened in large B-cell lymphoma. Prior to CAR-T, refractory, chemo-resistant large B-cell lymphoma had dismal outcomes. Then CAR-T cell therapies got approved. In third line, axi-cell, Trisagen-Leclucil, Lysocell basically got approved in patients with relapsed refractory large B-cell lymphoma who had experienced 2 or more lines of treatment. Now, it's important to identify what's the difference. Remember, with axi-cell, the co-stim domain is CD28. With Tisagen and Lysocell, the co-stim domain is 41BB. Why does it matter? Co-stim domain basically tells us how does the construct expand. With axi-cell, the construct expands robustly and very fast. Therefore, there is a higher grade CRS, there is a higher grade neurotoxicity. With 41BB constructs, this is more controlled and slow, and that again reflects in the incidence of low-grade CRS and ICANS. What's the biggest takeaway? The biggest takeaway is that CD19 CAR T cell therapies actually can cure 40% of patients in third-line diffuse large B-cell lymphoma, wherein previously they only had a cure rate of 10%. So clearly, this is something that needs to be moved ahead. And what we so far know is based on two randomized controlled trials that basically compared axi-cell to autotransplant and lysocell to autotransplant. These were two positive clinical trials that established CD19 CAR T cell therapies, axi-cell and lysocell, as the new standard of care compared to autotransplant, which used to be a historical 3-decade standard. Unfortunately, Belinda, which was Tisacel versus autotransplant, was a negative study. I also want to be mindful of helping everybody also recognize that this was done in fit patients who had relapsed within a year or just wouldn't respond to chemoimmunotherapy. And these are the minutiae of the details across the clinical studies. Axi-cell, only steroids were allowed. Crossover was not allowed. Lysocell, 1 cycle of salvage chemo was allowed. Crossover was allowed. Median PFS across both studies significantly better compared to autotransplant. With regards to grade 3 or higher CRS and ICANS, you can see that this was higher on the Zuma 7 compared to the Transform platform. So the big question is, can we cure patients in second line high risk diffuse large B-cell lymphoma setting? And the answer is yes, we can. At the 4-year follow-up, the median overall survival on axi-cell was not met. This translated into a 4-year overall survival of 55% compared to 44% on the auto-transplant arm. This was statistically significant. There was no crossover built on the protocol. With lysocell, we see the same pattern. We now have a 4-year follow-up as well. The difference is not statistically significant because 62% of patients crossed over to receive lysocell. And usually, this is why the overall survival is not yet seen, because patients got lysocell at progression right away. The big question I get from my community partners is, why does it matter whether you do CAR T cell therapy in second line or in third line? And I usually give them this data that if you do it in second line, the 2-year progression-free survival and event-free survival is superior than when you get it in third line. There's a 20% difference, 95% versus 78%. So the big question is, can I do CAR T cell therapy in unfit patients? And the answer is absolutely yes. This is based on the pilot study. Median follow-up of 24 months. Overall, I can say that this is a frail population. The biggest takeaway is that the primary endpoint of overall response rate of 80% is met, but there is no toxicity that is high grade. There were no grade 4, 5 CRS or ICANS. Also, the infection risk was minimal at 7%. The logistics of CAR T cell therapy are clearly quite cumbersome. At this point in time, we have to first undergo apheresis after insurance authorization. So that's 2 weeks of delay. Then the cells are manufactured, they take 4 weeks, and then we infuse. So clearly the cancer is not waiting. So what is the trick to getting CAR T cell therapy approved for all and accessed for all? And I think the biggest barrier is not really pathology or biology, it's really delayed referrals. So in the United States, there is a huge rush to recognize brain to vein time. If you think someone is relapsing, refer right away because it takes a long time to get authorized, then get the patient apheresed, and then post manufacturing get them CARs. The clock is ticking. So in terms of bridging therapy, meaning what can I do to keep the cancer stable? That's all I need when I give them CAR T cell therapy. I could use steroids if the tumor burden is low. I could use radiation if it's a local site that's bulky. Now we have the ability to do CD20 bispecific T cell engagers as bridging therapy. I would not do that prior to apheresis because T cells could get exhausted. The same rule applies to bendamustine. Please avoid bendamustine prior to apheresis. You will compromise T cell health and affect the apheresis collection. I do know of several patients now that are getting CAR T cell therapy in India, which is amazing for patients there, but we need to set them up for success. So please, when somebody refers and you're thinking CAR T, please talk to the CAR T site so that you can plan bridging therapy, holding therapy in that regard. Also, I would tell you that age is not a bar. We don't know at this point what truly constitutes CAR T ineligibility, but I will tell you that transplant eligibility is not the same as CAR T eligibility. I've taken patients who have a compromised cardiac function, pulmonary function, renal function, even patients with Parkinson's through CAR T cell therapy. Age is no bar. I've taken 89-year-olds to CAR T cell therapy. So, what is needed? Recognition is needed. Getting them seen earlier is needed. Getting them to referring physicians like cardio-oncologists, cardiologists, pulmonologists to optimize organ function is what is needed. I usually tell my community partners, if you think this patient can handle GEMOX, the patient is likely to handle CAR T cell therapy. What you read off with regards to CRS and ICANS, it's primarily in the times when we didn't know how to recognize these toxicities. With 4-1BB constructs like lysocell, patients usually are just bored in the hospital. So at this point in time, CAR T cell therapy can be given to unfit patients. What's the next frontier in CAR T cell therapy? Of course, with third line, you cure 40%. With second line CARs, you can now cure 55%. But we need to do better. And with that, we have actually launched BICAR studies. So this is the next wave of clinical trials. We opened one at our site. I've enrolled 2 patients already. These are phase 3 randomized clinical trials that are comparing lysocell or axicell to BICARs, which is 1920. So the idea is the ability to generate a CD19 resistance goes low if you do BICARs. This is the initial toxicity and efficacy profile, and it's actually looking extremely encouraging. So with the Lyell platform, the CR rate is 74%. With the Kite platform, it's 78%. This is in a heavily pretreated setting. So the hope is that maybe at some point, even lysocell and axicell can get displaced. Now let's go on to the next frontier with CD20 bispecific T cell engagers in diffuse large B-cell lymphoma. They are currently approved in third line, and one has been approved in second line. So we have glofitamab, time-limited, 12 cycles IV infusion. Epcoritamab, subcute, indefinite treatment. What's the takeaway? So right now we have 3 bispecific T cell engagers, 2 in the US and 3 in EU. The one in EU is odronextamab. Pretty much similar. Overall, the best complete response rates are actually 40%, and half of these patients are still in a remission 2 to 3 years out, which basically begs the question, are we curing anybody who gets CD20 bispecific T cell engagers? Remember, the grade 3 or higher infection rate continues to be 15 to 30%. That's a lot. So, which somebody gets COVID, they would likely be in the hospital for a long time, precluding further bispecific T cell engagers. So, it's very important to recognize early toxicity, to hold the drug, to take care of the infection, and then resume the drug. So in terms of what is happening with bispecific T cell engagers, there is tremendous scope to actually combine it either with chemotherapy or antibody drug conjugates. So with that, you can see we have the STAR-GLOW data that is currently not approved in the United States, which compares glofitamab GEMOX versus our GEMOX. Complete response rate high, median has not been reached for complete responders, and the median PFS is 14 months. Now you can see the same trend with epcoritamab and GEMOX. And then there was the SUNMO data that basically compared MOS and POLA versus our GEMOX. And in this, the CR rate was slightly lower, but the median for people who got a CR was not reached, and the median PFS is 11 months. So the big question is, where would I use these regimens? Because second line right now is curative intent CAR T cell therapy. I think in patients who cannot wait for manufacturing, patients who cannot get to a CAR T treating site because their caregiver is not available, patients who just are not able to leave their home. I think they can potentially finagle every 3-week infusions in a cancer center, but probably not a relocation for 2 weeks in the United States for CAR T cell therapy. So, in terms of what is the biggest debate with StarGlow, the biggest debate is there was a stellar median PFS benefit compared to GEMOX. I think there are two issues here. GEMOX is probably a straw man comparator. Anybody can beat GEMOX, but that is all we had. Now, the second question is, do we actually need GlowFit GEMOX for 8 cycles? Or could we drop the GEMOX after a few rounds to limit the toxicity? And the biggest other issue is that in North America, the hazard ratio was actually unfavorable for this combination. There was no difference. It was only 25 patients, so it's probably underpowered analyses, but it was actually beneficial everywhere else. So Europe, Asia, there was a striking benefit. So I do believe in CAR T inaccessible areas. GlowFit GEMOX is a very good regimen, but the caveat is that we don't have a 5-year follow-up, but the 2-year follow-up looks quite striking, almost comparable to CAR T cell therapy. So in terms of what's happening in the United States with frontline studies, bispecs are moving ahead. And with that in mind, we have GlowFit plus Polar Chip versus Polar Chip, Sky Glow, the same with EPCO, the same with ODRO. These are all completely enrolled studies. And because they are completely enrolled studies, we are basically awaiting their results. Now let's switch gears to follicular lymphoma and talk about key updates in follicular lymphoma. With regards to follicular lymphoma, we definitely know that overall survival decreases by every line of treatment. Also, we do know of a unique entity called POD24, where if patients relapse within 24 months of initial chemotherapy, their overall survival is compromised. So what do we have in relapse follicular lymphoma? We of course have the 3 CAR T constructs, but we also have CD20 bispecific T cell engagers. What I am going to show you is long-term data. So axi-cell, higher rate of CRS, higher rate of neurotoxicity, but you look at this curve, 5-year PFS, 50% of heavily pretreated relapsed refractory follicular lymphoma patients are in a remission. This is stellar. We hesitate to use the word cure, but I think I am about to start thinking that these constructs could potentially be curative. Same story with Tisacel. 46% of patients completely in remission 5 years after. In fact, the first author of this study went on to say if there is no relapse reported after 36 months, you can be rest assured the patient is cured. Lysocell, 3-year follow-up, looking quite good, probably much better than anything else we have seen so far. So 36-month profile, 68% of patients still in a remission. Now let's look at the long-term follow-up with mosunetuzumab. 5-year PFS is good. It's not as good as CAR T cell therapy, but 36% of patients are still in a remission after completing mosunetuzumab. I'm not a big fan of epcoritamab primarily because it's given indefinitely. So there is a lot of B cell depletion, lots of infections, grade 3 or higher infections here with 35%. So if there is a choice, I typically go with mosunetuzumab. But if there is a concern that maybe somebody had occult transformation, then I go with epcoritamab. Now let's go on to where is epcoritamab going. So this recently got approved based on a stellar presentation by Lorenzo Falchi in second-line follicular lymphoma, where patients were randomized after having seen 1 line of chemoimmunotherapy or more to either R-square or EPCO R-square. This was a 1-year commitment, and this was a dual primary endpoint. In terms of the dual primary endpoint, PFS was stellar. You can see we have never seen hazard ratios like this, 0.2, which translates into an 80% risk reduction. Median follow-up is 16 months. It's short, but this curve is really incomparable. The same goes for the other dual primary endpoint, which is overall response rate, 95%, translating into a CR rate of 83%. Now, in terms of overall survival, it looks like it's better on the EPCO R square, but time needs to really figure out if on long-term follow-up this actually holds true. What is the biggest takeaway for me? I think it's a stellar regimen. I will definitely use it and have been using it in second line, but the risk of infection. So if you see grade 3 or higher infection is higher on the EPCO study compared to the R square, 33% versus 16%. So please be mindful of that. Bispecifics are actually also being launched in frontline trials. In high tumor burden FL, there are 3 frontline studies using 3 constructs going head to head with chemotherapy. And this is either single agent bispec or plus R square. In terms of low tumor burden follicular lymphoma, a lot of times people are recommending watch and wait. People who get anxious, they get rituximab. But the concept of cure is beginning to surface very quickly in follicular lymphoma. And from the standpoint of cure, this is a study that is itching to try to cure follicular lymphoma. So this is a low tumor burden study, randomizing patients 1:1 to either rituximab for 8 cycles or mosunetuzumab for 8 cycles. For the patients I have enrolled on this study, half of them got rituximab, half of them got mosun, and honestly, I couldn't tell because CRS rates with mosunetuzumab were almost negligible. Mosunetuzumab is now also available as a subcute formulation. Now let's switch gears to classic Hodgkin lymphoma. In terms of classic Hodgkin lymphoma, I think in advanced stage classic Hodgkin lymphoma, the RATHL study first changed the course, figuring out if everybody needs ABVD and needs to get exposed to bleomycin. So in this study, 2 cycles ABVD, interim PET, if it was negative, you could de-escalate therapy to AVD and achieve similar outcomes. So with that in mind, RATHL became the standard of care. Then came the Echelon 1 study, which basically randomized patients to ABVD times 6 to A plus AVD times 6 in advanced stage disease. Echelon 1 met its primary endpoint, 5-year PFS 82%. Now remember this number because it's going to continue to keep going upwards. 5-year PFS 82% versus 75% with ABVD. Overnight became a standard of care, especially when overall survival started also becoming clinically significant for A plus AVD. But brentuximab is not everybody's business because patients can have a lot of neuropathy, neutropenia, infections, and thus came the SWOG study. 1826, where patients got randomized with advanced stage Hodgkin to either nivolumab plus AVD for 6 cycles or brentuximab plus AVD for 6 cycles. And this showed a 1-year overall survival of 95% versus BVAVD at 83%. You know, this is the real number based on the Echelon 1 study. Moving forward, we do have a 2-year data that actually holds true, where the 2-year and now a 3-year PFS is over 90%. So from 83%, we are now moving on to 90%. Nivo plus AVD is thus the new standard. However, patients who have autoimmune disease can potentially not get nivolumab. And therefore, in those settings, we have HD21, which actually replaces Biacop with Briacad, where the idea is to give them brentuximab instead of bleomycin. So this is also a bleomycin-free therapy, and this is PET guided. You start with 2 cycles of Briacad. If the interim PET is negative, you give only 2 more and you're done. So patients are actually done with 4 cycles, but there is a higher risk of toxicity, higher risk of supportive care, more transfusions, and obviously more cytopenias, neuropathy, but the risk of gonadal toxicity and second primary malignancy compared to Biacop is way less. So moving forward, this is now the standard paradigm for advanced stage Hodgkin. We now talk to our patients about Nivo AVD times 6 or Briacad, either 4 to 6 cycles. That would be PET dependent. Last but not the least, I have to touch upon BTK inhibitors. Obviously, I couldn't really finagle a CLL lecture here, but BTK inhibitors made a big splash in CLL and then subsequently in mantle cell. We have second generation ACAL, zanubrutinib approved in mantle cell. Ibrutinib actually got withdrawn from the US, so we cannot use it. But we also have pertobrutinib, which is a non-covalent BTK inhibitor that's approved in 2023. So, what has changed in mantle cell lymphoma? Historically, if patients were fit, we wanted to give them super toxic chemo followed by autotransplant. Then came Michael Wong from MD Anderson, which actually showed on the Windows study that incorporating a BTK upfront with chemo was feasible. CR rate was high, and the 5-year PFS was stellar. And based on that, the Triangle study got designed. In a nutshell, Triangle study basically is a large study conducted in Europe where patients with fit mantle cell lymphoma, transplant eligible, were randomized to getting chemo with a BTK inhibitor, followed by autotransplant with a BTK inhibitor, or chemo with BTK followed by autotransplant, or chemo with no BTK followed by autotransplant. So it was comparing the autotransplant standard to autotransplant plus BTK or BTK alone. And this trial changed how we treat fit patients with mantle cell lymphoma. The net is that patients who receive BTK inhibitor upfront followed by maintenance do much better than patients who get auto transplant. Now, the big question is, can we still give them auto transplant if a BTK inhibitor is not available upfront? I think we can, but you can see the failure free survival here in each of these arms, especially in the no superiority of auto transplant versus a BTK alone. But this basically, in my opinion, puts auto transplant to rest. I have not been taking any patients to an auto transplant for the past 3 years who have had mantle cell lymphoma and are young. Now, the big question is, what about TP53 mutation positive mantle cell lymphoma? This is a very unique subset. 20% of patients are enriched for TP53 and they do not do well, even if you give them a triangle-like regimen. So in this setting, just like we do with CLL, TP53 mutation, you really don't want to give them chemo. And from that standpoint, we have the Bowen study, which is zanubrutinib, obinutuzumab, and venetoclax in patients with treatment-naive TP53 mutation mantle cell lymphoma. Small n initially, now it's actually much bigger on a further follow-up, but the range was 29 to 82. So it took care of fit and unfit patients. Overall, this was a 2-year program or until MRD became 0. Overall response rate 96%, CR rate 88%. 2-year PFS 72%, and the median has not been reached. So this is now on the NCCN guidelines. And usually, whenever we get a patient with mantle cell, we first check for TP53 aberration. This can be detected on FISH as deletion 17p and NGS TP53 mutation. Just because your FISH is negative, it does not mean that NGS will be negative too. So please, when you have someone with newly diagnosed mantle cell, you have to check for FISH as well as NGS. So in conclusion, I do believe that frontline treatment of DLBCL is going to continue to evolve. For now, pola-R-CHP remains my favorite for IPI2 and over. However, if somebody has neuropathy, when tafa-len-R-CHOP gets approved, I will likely use it in clinical practice. CAR-T has fundamentally changed everything about relapse refractory DLBCL, offering a cure in 40% in third line, 50% in second line. It's also being moved to front line. Bispecifics are currently being used in second or third line, but I think the true space for bispecifics may be in the front line. In follicular lymphoma, I think a lot of us are going to have to do bispecific antibodies and CAR-T because the durable disease control is quite intriguing, hoping for a cure in an otherwise incurable disease. With mantle cell lymphoma, it's the era of BTK inhibition, cellular therapies, no more transplant, in my opinion, but in a resource setting where BTK inhibition is not available or patients cannot afford it, I think transplant is fine in CR1. Hodgkin lymphoma, Nivo-AVD is my go-to. But in a very fit patient, especially male, where the gonadal toxicity is not an issue as it is in females, I think Briacad in a PET-directed approach could also be considered. I hope this is helpful, and I will be open to questions. Again, I'm really sorry for the delay.
Can you hear us?
Yes.
Okay, good. So questions, please. So there was some discussion, it occurred before you joined us. And I think you answered this, that you will prefer to give Pola-R chip to everybody, irrespective of their ABC or GCB status.
Yes, and I think this is a very highly debated topic in multiple sessions and forums. I think there are investigators who will say absolutely not for GC, and I am on the other side of the spectrum where I'm looking at toxicity. Uh, there is no toxicity difference between R-CHOP and Pola-R chip. And I'm looking at the fact that we are unable to do gene expression profiling to really figure out who is GC and ABC. So for now, my plan would be to give Pola-R chip until something really displaces that in a true manner.
Right. There's a question that has come up by Dr. Rushni. Can genetic variations in CD19 cause different outcomes with CAR-T therapy, like increased chance of resistance to the therapy?
Yeah, I think she's asking a great question. We did have a presentation that was actually done from the UAE at the most recent ASCO meeting, which actually did show that people from the Mediterranean region were enriched for a different variation genetically in CD19, wherein the impact of CAR T cell therapy could be different. I don't think we have it absolutely there yet that they will do poorly. So something that is curative intent, I do not check for CD19 prior to giving CAR T cell therapy. We'd have no way to look for splice mutations or loss of antigen. It's also something that I will say is very different than what I do for CD20 bispecific T cell engagers, where I absolutely check for CD20. Because if CD20 is negative, CD20 bispecific T cell engagers will not work.
Right. Any question from colleagues present here? Yes, Amit, go ahead.
Wonderful talk, Dr. Manali. Regarding this TP53 positive mantle cell lymphoma, the Bowen trial has come a big way out with zenobrutinib plus obinutuzumab and venetoclax with a good overall response rate. But Zenu is not available in Indian market. Can we replace it with acalabrutinib?
Absolutely. I think we have great data with the Traverse study that also got presented, and I think AVR would be a very reasonable change. I do believe in mantle cell lymphoma, just like CLL, obinutuzumab may be a little more cytoreductive than rituximab. So if possible, I would use my CD20 partner to be obinutuzumab. But with BTK inhibition, no issues to replace and interchange it with acalabrutinib.
Thank you. And this is true for every age of the patient, like all age of the patients, elderly, young patients, young age, because this one not won't increase the toxicity in elderly
So
patients.
that is Yeah, that's absolutely correct. And that is what Bowen actually shows in terms of its real strength. The real strength of Bowen lies in the fact that patients who are 20 and patients who are 90 could actually receive it. There was slightly higher diarrhea, so you need to account for that. But the beauty of Bowen is that you don't have to get started with the anti-CD20 antibody right away. You could also do it like the Amplify study, in CLL, where you can start with a BTK inhibitor, make it easy for the patient, and in month 3 come in with venetoclax, maybe month 2 come in with an anti-CD20 antibody. It's all about debulking. So if someone has a lot of tumor burden, I usually just start with the BTK inhibition, then introduce anti-CD20, then introduce venetoclax. We do have an ability to do MRD platforms here based on clonoSEQ. So I don't know if clonoSEQ is something that we can send in India. Are we able to send MRD in India?
We are not doing by clonoSEQ, I think so, sir. Anywhere it's done, I don't know.
MedGenome is sending it to US.
Perfect, perfect. And the turnaround time, sir, is how long? Is it 6 weeks, 4 weeks? Okay, so I think it would be helpful if we choose bovine, that at the end of the 2-year program, we check an MRD, because the idea is to bring these patients to MRD 0 levels. So that test, end of treatment, would be hugely valuable to basically tell your patient if you need to keep going with Xanu plus venetoclax, or you can actually stop it.
Thank you. Another question regarding mantle cell lymphoma is there any subset of patient where BTK inhibitors should not be used?
Wow, what a question. Uh, and so I don't promote BTK inhibitors commercially, but now that you're asking this question, I think I wouldn't really. So for fit young patients, I would do BTK upfront, like the triangle study. For TP53 patient, I would do BTK upfront. Where would I not do it? I think in elderly patients who don't have TP53 aberration, we have the ECHO study. I didn't have time to show the ECHO study today, but ECHO basically compares bendaritux to bendaritux acalabrutinib followed by acalabrutinib indefinitely, and it showed a PFS difference. I think in a very fit elderly patient, I might consider a BTK inhibitor upfront, but if a patient is elderly, otherwise okay, and no TP53, I would just do bendaritux, because if you look at the 5-year PFS data, it is not bad. It's 65%. So if someone who is 75, if there is a 60% chance that when he turns 80, he's likely still going to be progression free, why give them the triplet? Because adding the triplet induces cytopenias, diarrhea, discontinuation. So that's probably when I will not consider a BTK upfront.
And what about blastoid variant of mantle cell lymphoma?
Blastoid variant of mantle cell lymphoma is a tough cookie to crack, because I do believe that blastoid variants may or may not be enriched for BTK mutation, right? So if they have a BTK aberration, you have a blastoid and you have a BTK. That's a double whammy. You have to tackle them with chemo-free targets. Usually I go for bovine. And I'm really looking forward to how they are doing, because the minute they don't do well, what I do here is I switch them to pirtobrutinib and either take them to glofitamab, or I take them to CAR T cell therapy, or I take them to a clinical trial. But say, for example, a blastoid patient does not have TP53 mutation, right? So this is a patient who may actually do quite okay. So if you look at the triangle study, blastoids were okay with an auto transplant. So I don't know if in those patients I would actually consider an auto transplant and a BTK inhibitor. I think that would be the only setting. But I think there are so many treatments downstream that we have to acknowledge upfront toxicities, because auto transplant puts a patient at risk for 6 to 10% of second primary malignancies, right? So when they relapse, you don't want to also have a prostate cancer that you are doubly tackling while a mantle cell is also brewing. But otherwise, for a blastoid elderly, say for example, with or without TP53, I do the ECHO paradigm, which is BR plus A. That's how I look at it. And I will tell you, mantle cell is one disease where it's so heterogeneous that if you ask 5 people, you will get 5 correct answers. That's the biggest difference about mantle cell lymphoma.
True. Thank you so much.
Talking about mantle cell lymphoma, what's the role of POLA in mantle cell lymphoma?
So I will say I'm a huge proponent of Pola. Again, I don't speak for the company, but we had a clinical trial that was open with mosunetuzumab and polatuzumab. It's now a published manuscript. Please look at it because the results are really good and it's extremely well tolerated by patients. It's currently used as a relapse platform, but patients who relapse with mantle cell lymphoma, mosunetuzumab plus polatuzumab gives them a CR that is very decent and durable. So this is actually going to be tested in an upfront setting to see how these patients do. Mosin Pola has probability to get approved in Japan, other places in Asia. Sir, I don't know if it's going to be approved in India, Mosin Pola, but if it is, I think it's a very good doublet for elderly relapsed DLBCL patients who cannot get to CAR. You get some decent durable responses, and in mantle cell lymphoma at relapse if they cannot get to CAR T cell therapy or pirtobrutinib is not approved. So yes, I think there is where I look at Pola. Where else do I look at Pola for mantle cell lymphoma? If I'm looking for immediate debulking, patient is very sick, I admit the patient sometimes, and I have given them multiple combinations with Pola. Sometimes it's polatuzumab and obinutuzumab. Sometimes it's polatuzumab and glofitamab. Obviously, none of this is data driven, but so far I've been able to keep these patients stable till I get them to a consolidative platform. That consolidative platform could be an allo. That consolidative platform could be CAR T cell therapy.
Sure. In double hit lymphoma, DAR epoch or Pola R-chip?
You are throwing a lot of hard questions today. I think in double hit lymphoma, I go with dose adjusted EPOCH-R followed by 2 doses of high dose methotrexate. That's been my approach for double hit lymphoma because it is a large study that did show benefit, albeit it was only, just that one study. But with Pola R-chip, the issue was that there were not a lot of patients. There were only a handful of patients who had double hit lymphoma, where Pola R-chip was better than R-CHOP. But R-CHOP we know is not a good backbone for double hit lymphoma. Hence, my choice is dose adjusted EPOCH-R. I also make sure that when I give them that first cycle of dose adjusted EPOCH-R, I do intrathecal methotrexate and test their spinal fluid for flow and cytology, because you want to make sure there is no inherent ongoing lymphoma in the spinal fluid, because then your regimen should completely change. So I typically do dose adjusted EPOCH-R, 1 dose of IT methotrexate with an analysis of the spinal fluid. If negative, I do 5 additional cycles of dose adjusted EPOCH-R followed by high dose methotrexate, cycle 1 day 15 and cycle 1 day 30.
Thank you. A question Dr. Apurva has put up: any therapeutic implication of interim PET scan in DLBCL in 2026?
I think there is going to be significant value to actually looking at an interim PET. It has only shown prognostic value, but it is very likely going to be done predictively. And we have a couple of clinical trials that are establishing that already. For example, the Zuma study that looked at interim PET positivity in high-risk patients. Patients were randomized to basically getting CAR T right away. So here, I do believe that ctDNA or MRD platforms are going to also be extremely important. And I think the biggest thing for us in India to do is to make ctDNA platforms available, because they are going to be predictive. So there is the Alpha 3 study, wherein patients at the end of treatment, if they are ctDNA positive, are being randomized to getting either observation or an allo CAR. And looks like the initial press release showed that MRD positive consolidating with something is likely going to be a new standard. So I think if there is one area to focus on in India, is to be able to do this prospectively for our patients who get frontline DLBCL, even more so than molecular profiling. I think molecular profiling is at least 4 years out, where you look at the biopsy, you say it's C5, okay, now we'll target it with the BTK inhibitor. I think it's not ready for prime time anytime soon. But this MRD MRD platforms, they are likely going to be ready very soon. So I encourage hematologists in India to really partner with this company, which has made this platform commercially available, because it is going to be of value to figure out if end of treatment, even if the PET is negative, MRD is positive, their PFS is only 28%. So I think we are going to eventually make MRD actionable. It's also very important to incorporate this moving on, because it helps a lot of end of treatment positive disease. So end of treatment, everything has melted. Everything is DS1, 2, 3. But there is one unique site deep in the retroperitoneum, that's Dovil 5. And it's not new. It's just there, but it's bright. This is a place you cannot biopsy. But if MRD is positive, you know there is disease and we need to do more.
Right. Dr. Roshni had put another question. Testicular lymphoma stage 1A, 6 by 6 centimeter mass. How much chemo is enough? 4 cycles or 6 cycles of R-CHOP? And is high-dose methotrexate better than intrathecal methotrexate in this setting?
Yeah. So for testicular lymphoma in the limited stage setting, I would definitely still do it according to the SWOG study, which was 4 cycles, but make sure that you discuss your PET with the radiologist. If there is any doubt that this is not a Dovil score of 3 and under, give them the full 6 cycles. But if it is a Dovil 2 and 3, please just give them one more cycle, 4 cycles of R-CHOP. But in terms of prophylaxis, this is a CNS privileged site. So there is definitely a higher risk of metastasis, not metastasis, but dissemination to the CNS. And thus, I prefer high dose methotrexate. In a testicular lymphoma patient, I do 1 cycle of intrathecal methotrexate with the first cycle of R-CHOP. I want to make sure there is no inherent CNS positive disease, and then scrotal radiation. That will complete the CNS prophylaxis portion. The one thing about testicular lymphoma is relapses can happen extremely late. So please don't discharge them from your clinics at the 5-year mark. I have seen patients relapsing at the 8 and 9-year mark. So especially testicular is something that I will follow for a very long time.
Right. In Hodgkin lymphoma, newly diagnosed, advanced stage, the Bricard therapy, if your PET scan is negative after 2, you are extremely comfortable in giving 2 more and stopping the treatment?
Yes, I am. Yes, I am.
Okay.
Again, the definition of Dovil score, though, really, I think it's important that we pick up the phone and speak with the radiologist. If there is any concern, please complete it and treat the patient like Dovil 4 and over.
Right. How much is the risk of nivolumab-induced autoimmune disorders in Hodgkin?
So right now, what we have a signal with is with autoimmune thyroiditis. I think this is clearly a signal, so we must monitor TSH with every cycle that we give with Nivo-AVD. Please make sure that you work closely with an endocrinologist, because a lot of times thyroiditis after completion of nivolumab, it has a long half-life. So sometimes after 8 weeks, the dose of the dose of levothyroxine may need to be changed. Sometimes it just stays. Sometimes the thyroiditis worsens. Also, the manifestations can be different. They can have a hyper phase and burn out into a hypo, or they can start off with the hypo phase and then have to be on Synthroid for a long time. But outside of that, the risk of other toxicities like hypophysitis is actually very, very low. Overall, Nivo-AVD is a very unique platform with very manageable toxicities. I typically do not even give growth factor support. So I treat it like ABVD. If the patient is neutropenic on the day of needing chemotherapy, as long as they don't have mucositis or a fever, we can just keep going with Nivo-AVD. The issue is if patients have an existing autoimmune disease, then we don't know if we can give the Nivo. And I think in those settings, we may have to relegate to AAVD and hope for an 80% cure. Hodgkin is definitely a place where the cure rate is above 80%, whether you choose AAVD, Nivo AVD, or Briacad. But if you want to get to the 90%, I choose the Nivo AVD platform.
Dr. Amit, your question.
Yeah. Regarding use of polatuzumab in case of intravascular large B-cell lymphoma, is it okay to use pola for intravascular large B-cell lymphoma also? Because when
I think it is totally fine to use polatuzumab for intravascular large B-cell lymphoma. It's just that we don't have data. And because we don't have data, I think we can extrapolate and say that there were about 30 patients with high-grade B-cell lymphoma. Intravascular diffuse large B-cell lymphoma could have probably been a solitary patient or two. With intravascular DLBCL, my go-to has still been a high-grade B-cell lymphoma regimen, which is dose-adjusted EPOCH-R, because the likelihood that it can disseminate to the CNS is high. So I typically follow a path that I follow for double-hit lymphomas for intravascular B-cell lymphomas as well.
Thank you.
But Dr. Khurana, I think the issue is that these patients may just be enriched for frailty, because this is also a disorder, intravascular DLBCL, that you see in the older patients. And in those settings, getting them dose-adjusted EPOCH-R may actually be very hard, because the beauty of dose-adjusted EPOCH-R is to dose adjust. And if you cannot dose adjust, and if you cannot go higher, then you're basically giving them CHOP with etoposide. So if you can, I would consider a double hit platform for them. But if they are frail, usually intravascular diffuse large B-cell lymphomas are non-GC subtype. So Pola-R-CHP may actually have a unique advantage to that subtype.
Thank you.
One question. How is the Pola-R2 in DLBCL? Pola, Len, rituximab in DLBCL.
So I think we have, I think we don't have a lot of data right now in frontline. This platform is not moving forward because it's made by the same company that makes glofitamab, and they have seen a 1-year PFS of over 86% with glofitamab plus R-CHP Pola. And I showed you the 1-year PFS with our Pola Glo. So R square is not likely going to be incorporated. But I will say that there is going to be a goal-seek study that is testing a better lenalidomide called golcadomide. So golcadomide plus R-CHP Pola is moving forward to a phase 3 study in comparison with R-CHP Pola. We did see initial results at ASCO. Again, CR rates upwards of 90%, PFS durable at a short follow-up, but huge amount of febrile neutropenias, discontinuation. Golcadomide is actually more fatigue inducing. Patients have a lot more cytopenias. So when we do immunomodulators, the trick is to prophylactically dose reduce. If you start seeing some of these symptoms already, don't let the patients go through it before they become so frail that they cannot take even a little bit of the dose. So if you choose lenalidomide or eventually golcadomide, it's going to be a lot of clinical interaction with patients to figure out the right sweet spot for them.
Right. How many cycles of Pola-based treatment are ideal as a bridge to CAR-T?
I typically bridge my patients only with one cycle of anything. So typically after apheresis, we have 3.5 weeks, 17 days for axi-cell, 22 days for lysocell. And with that timeline in mind, I typically only do one cycle.
Is there any place for Pola after CAR-T?
It would probably be a place if Pola has not been given upfront. And if patients have relapsed after CAR T cell therapy, now we have the option based on Polargo as well as Sunmo that you could do Mosin plus Pola, or you can do Pola, Ritux, Gemox. I prefer polatuzumab with a bispecific backbone. I think there is a unique tumor microenvironment reason for why it might be better than subjecting patients to chemotherapy.
Okay. Any other question, please? No. So I think we have covered all the questions in the chat box as well as people from here. So Dr. Manali, thank you very much. This was wonderful listening to you on this update. It was very informative. I think everybody benefited. Besides those who are present here, there are a large number of audience all over. So it's great.
Thank you so much for your patience with me this morning. I'm really, really sorry for the late start.
Not at all. Thank you so much. Is Mr. Sumit there?
He's there.
You can deliver the vote. Thanks. Yeah.
Yes, sir. Thank you so much, Dr. M.B. Agarwal and Dr. Manali Kamdar, for sparing your valuable time. Both the sessions, the first one and your session, Dr. Manali, was very, very engaging, and presentations were excellent, and discussion was further great. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. And I also thank all the discussants and participants who have joined us for this webinar. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. Thank you so much, everybody, and have a wonderful evening.
Thank you.
Thank you very much. Have a good night.